Program Manager for the California Opioid Safety Network at the Center for Health Leadership and Practice, a program of the Public Health Institute. You are about to watch a webinar that has been condensed from its original format to provide specific content regarding strategies to prevent overdose deaths. During the webinar, we will cover trends, existing strategies, and lessons from the field. The subject matter expert for this webinar is Dr. Matt Willis, our clinical lead for the California Opioid Safety Network. Let's get started.
Hi, everyone. Our vision is moving towards zero opioid overdoses. And to get there, we know that we need to simultaneously be addressing the problem of opioid oversupply and availability, high opioid demand, and to take new steps to prevent overdoses in real time. I'm going to start with some trends in opioid overdose deaths for the state of California. The best way to understand the strategies that we're talking about today here is to think that given that opioids are misused and addictive, how can we prevent the harm we know is associated with opioid use? So it's sort of a pragmatic and humanistic approach that says, even as we work to limit the supply of opioids through safe prescribing and drug take-back, reduce the demand through access to treatment, we know that people will be using opioids in ways that could harm them, and we want to keep them alive and as healthy as they can be as they move towards recovery. We have available to us the California Opioid Dashboard for any of us looking to be data-driven in our work, and you have access to that data for your county and zip codes within your county. And I'm going to offer some of the data from the dashboard. So this was a study that was done last year looking at 10 different scenarios and projecting out the number of overdose deaths we might see over time based on the strategies that we implement collectively across the nation. The bad news is that this highest line where we see the highest number of overdose deaths over a 10-year period is in fact our current trajectory. And what this invites us to do is to realize that if we are actually successful in the strategies we're moving forward in safe prescribing, in reducing demand through increasing access to medication-assisted treatment and harm reduction, we might realize that more optimistic lowest line, the blue line, that shows that we would be seeing a decrease in the number of overdose deaths, but only if we're able to successfully implement those strategies simultaneously and in parallel. What this shows across the nation is that we're seeing an acceleration of the opioid epidemic, and the primary contributor to that acceleration is seen here on the orange line that shows that synthetic opioids like fentanyl have emerged from 2015 onward as the major contributor more than prescription opioids. If we look at the state of California, going back to our dashboard, we see a remarkable increase in the number of fentanyl-related overdose deaths. There was a tripling in the number of fentanyl deaths in the state of California from 2016 to 2017. So that brings us to the phases of the epidemic, which is prescription opioids in phase 1. Phase 2, we're seeing more heroin use. And then in 2016, a rapid acceleration of the use in fentanyl. So the question, I think, for us as leaders in this space is how do we adapt our strategies to meet the increasing scope and complexity of this epidemic? One of the features that we need to acknowledge is that as fentanyl becomes more and more prevalent, there's different dynamics within the fentanyl epidemic, and it tends to be, as this graph shows, younger people. So some of the work that we've been doing in safe prescribing and increasing access to MAT may or may not actually address all the determinants of use and overdose risk in those youngest age cohorts, because those individuals may not have a history within their own life of antecedent, opioid prescriptions, and may not actually have some of the classic features of addiction. We're seeing much more lacing of fentanyl with other drugs of abuse like methamphetamine and Xanax and other benzodiazepines, as well as cocaine. In 2016, there was 42,000 opioid deaths, which was an increase of 345% from 2001. And what's important about that is that because of that age distribution being primarily younger, the years of life lost is over 1,600,000 years of life lost. So this is an epidemic that's affecting young people primarily, unlike some of the other problems of addiction and substance use that we see with alcohol and tobacco. They tend to affect people later in life. Synthetic opioids also, for the first time, eclipse prescription opioids as the contributors to death. So the author of this study said that we've been focused on the threat of prescription opioid overdose deaths, but that we need to remain vigilant about the ever-shifting nature of this crisis. This is a graphic that came out of Bloomberg that I thought was really helpful in terms of understanding the difficulty in controlling the supply side with regards to fentanyl. And basically what it shows is that there's more than 100 companies in China who are manufacturing and distributing and mailing fentanyl. The U.S. Postal Service and others just have no ability to manage and monitor every package coming. So harm reduction is both kind of a proper noun and a concept. When we talk about harm reduction, we're often, in opioids, we're often returning to naloxone strategies, needle exchange programs, and safe injection sites. But conceptually, harm reduction is, a constellation of policies, programs, and practices that aim to reduce the harms associated with the use of opioids rather than prevention of drug use itself. We accept that drug use is part of our world and work to minimize the harmful effects rather than ignore or condemn them. It acknowledges that some ways of using drugs are safer than others, and we establish quality of individual and community life and well-being, not necessarily the cessation of all drug use, as a criteria for successful intervention and policies. So this is one of the reasons why harm reduction strategies tend to be somewhat politically fraught in areas where people have different ideas and stigma related to drug use. So I'm going to start with strategies for naloxone distribution. As you probably well know, naloxone reverses opioid overdoses by having very high affinity for opioid receptors. When opioids contribute to fatal overdose deaths, it's because they are occupying receptors in the brain that not only control some of the known effects like pain and euphoria, but also respiration rate and other autonomic functions like heart rate. So when people are overdosing on opioids, essentially respirations are suppressed to the point where they may stop breathing, at which point you have about 3 minutes before the heart may stop and the brain will stop functioning. Naloxone can actually very aggressively replace the opioid on those receptors and restore normal physiology and normal breathing. So it knocks the opioid off the receptor. It only works on opioid receptors, so if there's no opioid on board, there's no effect, and there's no harmful effect if there's no opioids on board. It temporarily reverses the opioid effects, restoring respiratory drive, works in 1 to 3 minutes, and lasts for 30 to 90 minutes. It's neither a drug of abuse nor can it cause overdose, so it's important people know that it is not a drug of abuse. The only known contraindications are sensitivity, which is very rare. Obviously, if someone is opioid addicted and has changed their physiology, using naloxone can actually cause withdrawal symptoms, nausea, vomiting, diarrhea, chills, and other known symptoms. This is evidence of impact coming out of San Francisco. This was Philip Coffin, who's done a lot of work in the city on increasing access to naloxone. And basically, this was a study that looked at almost 2,000 individuals who were receiving prescriptions for chronic pain and offered them naloxone in a risk stratified way. So people who are on higher doses were getting offered naloxone at greater amounts than people who are on lower doses by primary care physicians and 6 FQHCs. And basically what it showed is, following those people prospectively over time, that after having been given naloxone, there's a significant reduction in emergency department visits related to opioid overdoses. But also importantly, that people who were given naloxone and the training that went along with that from the clinician were actually more aware and educated about the risks of taking too many opioids and actually changed their own opioid consumption practices and had fewer overdoses. Philip Coffin also did another study of cost effectiveness and basically demonstrated that there was about $421 per quality adjusted years of life gained, which, if you're looking at the data around qualities, is actually one of the most effective forms of of intervention in terms of the cost per year of life gained, and that 164 naloxone scripts prevented 1 death. And if you take into account the fact that people are actually disincentivized from over-consuming opioids when they have naloxone, that actually goes down to 1 in 36 opioid prescriptions in some of the models for saving 1 life. Another important potential barrier to distributing naloxone at the local level is that some people are afraid of the liability that may go along with carrying naloxone if it's not something that's been prescribed to them. And this is Assembly Bill 635, the Overdose Treatment and Liability Act, which basically allows bystanders to administer naloxone in an emergency protected from civil or criminal liability for adverse outcomes or practicing medicine without a license. This is another important piece of legislation, which is Assembly Bill 1535, which in September of 2014 authorized pharmacists to furnish naloxone without a clinician prescription in accordance with protocols approved by the Board of Pharmacy. The Board of Pharmacy did announce those regulations and is now legal for pharmacists throughout the state to furnish naloxone without a prescription. However, we know that a minority of pharmacies are actually taking advantage of that law. About 15 years ago, there was a huge movement to get automatic electronic defibrillators, AEDs, widely distributed throughout communities because people who are having heart attacks and had cardiac arrhythmias, there was a really strong correlation between the ability to shock someone back to a normal rhythm within a few minutes and overall survival. And so there was a lot of work to think about how do we get AEDs effectively distributed throughout the community. And this is just an example of one effort in Toronto where they mapped out cardiac arrest locations and then mapped out the locations where AEDs should be placed throughout the city in order to address that. And I'm encouraging us to think that way about our naloxone distribution across our community. So first is creating the call to action, educating regarding the local need, using local data, obviously sector-specific communications, so you would speak differently to law enforcement than you would to schools around this, and then also increasing overall public awareness. We can provide protocols, and there's an increasing number of canned protocols that are available that you can use, sector-specific, and some of those will be made available. Obviously providing the product itself, because we know this is a life-saving remedy and it's about $75 a dose, we want to make sure that the lack of product itself is not a barrier. And so the state and other funding agencies have actually made it more available for us to find special pricing or free access to naloxone for distribution at the local level. And there are at least 4 different modes of administration of naloxone. And then we want to, if possible, monitor the use of naloxone after it's been distributed, tracking the distribution, who we've distributed to, how many kits, and how many have been refilled. One opportunity there for actually tracking naloxone use at the local level is through emergency medical services data that you may have access to. That's something that the state has been helping support some counties in actually reaching out to their 911 system to get overdose death data, which allows us to see temporal relationships and geographic relationships in overdose events. And then importantly, celebrating the rescues. This is an example of some of the information we used in Marin to create the call to action for our clinicians, just using the local data to show that over half of all drug overdose deaths in Marin occurred at home, to make the case that we should make sure that friends and family have access to naloxone. Emergency medical services for first responders, the state requires that emergency medical services at the local level approve the training that's offered to first responders, and there are EMS-approved naloxone trainings available. Providing protocols, this is something we recently did in Marin working with our schools, and making the pitch to school nurses and school administrators. It's a lot easier when you have a protocol in place that you can share and say, this is what this would look like, and offer them a chance to edit and augment the protocol so that you find something that you can agree to. And monitoring use, this is an example of what we're doing in Marin around actually seeing the number of overdose events that are responded to by our EMS agency, and we can actually see the number that where the reversal occurred, and it really makes the case very effectively. We need to make it more widely available when we're seeing that 154 incidents in a small county like Marin. And then these are 2 examples of celebrating reversals in media. This was a story that aired right after we had trained our first responders in Marin, that a Novato officer actually saved an overdosing man's life. And this became one of the top 10 stories in Marin for the local newspaper. And then on the lower right, you have a picture of a librarian, I think in Humboldt County, who found someone in the stalls who had overdosed and used naloxone to save a life. This is an example of California Department of Public Health has made naloxone more widely available through public health departments. And these are some of the sectors that, as of March 2018, had naloxone distributed to them through CDPH. syringe exchange programs, substance abuse disorder treatment services, homeless programs, law enforcement agencies, and jails were all receiving naloxone through public health departments at the local level. So next, we're going to address needle exchange briefly. When we think about harm reduction and needle exchange, I think the simplest way to imagine this is actually through a really stark example that happened in Scott County, Indiana, a population of 24,000 people, so a small county. At 185 new cases of HIV over a 6-month period, young people, median age 33, mostly male and white. 92% of them were co-infected with hepatitis C. So there was a hepatitis C HIV outbreak of 185 cases in 6 months, which is more than you'd expect even in a city like New York City or Los Angeles. And most have been injecting Opana, which is a prescription opioid, and shared injection equipment. So this infectious disease outbreak really had its roots in opioid injection. So how do we prevent these sorts of things from happening? There's a clear argument for the cost-benefit of syringe programs. CDC did a study looking at vulnerable communities and jurisdictions that experience at risk for outbreaks, and California has counties that are at risk for outbreaks, partly because 7% of HIV infections in California were among people who inject drugs. The opioid epidemic, in some ways, as it accelerates, runs the risk of actually increasing our rates of HIV and hepatitis C, which had been, up to this point, reducing partly through the access of antiretrovirals and others. These are other infectious diseases associated with injection just from a harm reduction standpoint. If we're trying to support safe needle exchange, these are some of the other harms, and especially in the infectious disease space, that we would be preventing. And finally, safe injection sites. This is a more extreme version of harm reduction. This sort of takes the benefits of safe needle exchange and adds bricks and mortar to it and standardizes it as almost like a clinical intervention, where there are locations where people can come and actually under monitored and safe conditions engage in what is otherwise and what is illegal drug use in order to make sure that it happens safely, to reduce overdoses, and make sure there's someone there if there is an overdose event who can reverse it immediately, and make sure that the practices are safe. There's approximately 100 sites in 65 cities globally, and there's legislation still pending at the state to actually pilot safe injection sites in some California cities. San Francisco is probably the first site that would move forward with this, and they did a report in 2017 that estimated there would be a $3.5 million per year saved if one safe injection program were opened. In 1 year, one site would prevent 415 hospital stays and 19 hepatitis C cases, and 110 drug users would enter into treatment because they would have an opportunity to actually be identified and linked to care through that setting. So that's the quick overview of some of the primary strategies that we'll be diving into a little bit more strongly. This is Senator Scott Wiener, who is one of the real champions, proponents of safe injection sites. So we need to do everything in our power to keep people healthy, get them off the streets, and a safe place indoors instead of on people's doorsteps or in public parks, and we can intervene quickly if there's an overdose.
Thank you for watching this video. Please visit our website, CaliforniaOpioidSafetyNetwork.org, to access tools and resources, information on funding opportunities, and more videos in this learning series on opioid safety strategies and coalition development.